Good morning, everybody, and welcome. It's wonderful to see you all here today. Welcome everybody streaming online as well. I'm Kaz Nelson. I'm a Vice Chair for Education in the Department of Psychiatry here. And it's my pleasure to welcome Dr. Jeffrey Bishop, who's a clinical pharmacologist in the Department of Experimental and Clinical Pharmacology at the University of Minnesota. I'll tell you a little bit about his background, and then I'd also like to comment on some of the ways that he's helped us out with our education mission in the Department of Psychiatry as well. Dr. Bishop obtained his Bachelor of Arts in Biology at Luther College in Decorah, Iowa, went on as a genetics graduate program trainee at the University of Iowa Carver College of Medicine, obtained his Doctor of Pharmacy with distinction at the University of Iowa College of Pharmacy, obtained a master's in clinical investigation through the HK30 program at the University of Iowa Carver College of Medicine, and then went on to obtain postdoctoral fellowship training in pharmacogenetics and psychopharmacology at the University of Iowa College of Pharmacy, which he'll be talking to us about a little bit today. And so he brings this broad training and amazing experience over to the Department of Psychiatry to benefit us through grand rounds, but also in working with our learners up on the inpatient for professors' rounds once a week and getting into issues related to medication treatment and pharmacogenetics in a way which has really enhanced our learners' training, and I'm very deeply appreciative of that. And so without any further ado, I'll turn the microphone over to Dr. Bishop, and he's agreed to save a little bit of time for discussion and questions afterwards, so I'll be around with the microphone so everybody can hear and the people streaming online can hear later as well. Welcome, Dr. Bishop.
Thank you very much. Can you guys hear me with the okay in the back? All right, well, I appreciate the invitation, and it's exciting to be here to kick off 2017 Grand Rounds with you today. As far as disclosures are concerned, I'll talk a little bit about some off-label things related to pharmacogenomic testing. So as far as content's concerned, that's the only thing in the disclosure realm there. I'd like to make a personal disclosure, and that's that I had a dream last night. And the dream was that I showed up to give this presentation wearing cargo shorts and sandals and a sort of one of those Magnum PI style Hawaiian shirts. And I woke up thinking, like any psychiatry-oriented researcher might do, what does this mean? And furthermore, what better place to speak openly about questions regarding my dreams than is a presenter for Psychiatry Grand Rounds in front of an audience that arguably knows a lot more about the brain than I'll ever hope to know. So as I thought about it more, I was thinking, well, maybe this was, just some subconscious yearning for warmer weather or some sort of beach vacation. And then I got a little bit anxious and worried, thinking, well, maybe this is the Minnesota version of the dream where somebody shows up to give a presentation and to only find out that they're in their pajamas and their underwear, and that the brain has subconsciously adapted to the colder weather, thinking that even in the context of those dreams, one needs to cover up a little bit more. But anyway, after I thought about it more, what I really came to the conclusion about was that really it was my hope that this would be a relaxing and enjoyable hour for all of us to interact and hopefully have some nice discussion at the end. And those of you with further psychoanalytical insights can come talk to me later about my dream interpretations. So anyway, I have divided the next 50 or so minutes into two portions. The first part of the hour, I'll talk about things that are more clinically oriented regarding the current status of pharmacogenetic testing as it relates to medications that we commonly use in the mental health setting. Talk about what things look like right now as in terms of FDA-approved product labeling, consensus guideline evaluations, and what the status of those things are right now. Implications, challenges to utilizing this information, and I think opportunities that we have here to be further using pharmacogenomics to help patients in some scenarios. And then I'll transition into a bit of a research oriented presentation to talk about some examples of our ongoing work and how pharmacogenomics research has helped us uncover some novel mechanisms of drug action related to antipsychotic treatment outcomes. And so this is work that has gone on for a number of years, and it certainly can't be done in isolation. And so I like to acknowledge helpers and team members early on as opposed to waiting towards the end. So certainly we had a lot of willing study participants that helped out with some of the research that I'll talk about later, some grants that were instrumental in making this work go. Our pharmacogenomics laboratory here, Adam and Sine, have been instrumental in making some of the new work happen since my move here 2 years ago from Chicago. And of course my Chicago lab, as well as our first episode collaborators from the program that I was involved with there that I'll talk about a little bit later. And I always find it helpful to start with the bigger picture. And some people talk about the 200-foot view, and I personally like the 14,000-foot view from the top of Mount Elbert in Colorado. It's a reasonably achievable hike, and I believe it is the tallest peak in Colorado, but it's good for us being able to see the forest a bit before you get into the nitty-gritty details of the trees. And so I like to start out with that bigger picture perspective leading into how genetics and genomics can help us optimize treatment therapy by talking about how we approach intervention selection right now. And this is regardless of whether we're in the mental health setting, cardiology, oncology, et cetera. We tend to have guideline or algorithm-based approaches for which we have sequential selection of interventions or medications based on what we know from a plethora of data from clinical trials for individuals with specific diagnoses. We know that those selection strategies seem to work well for a lot of individuals, but I think a lot of us can appreciate that it's not all that uncommon that we have individuals who are intolerant to medications that we choose, or who may be tolerant but just don't elicit or exhibit the type of therapeutic or symptom response that we would expect given somebody's diagnostic classification or symptom presentation. And so we've been hearing a lot about these buzzwords such as precision medicine or personalized medicine. There's some of that happening locally here at the University of Minnesota, but also at the national level from the NIH. And the idea is that we're now in an era where we're now positioned to be using biological and genetic information in addition to the clinical and family history information that we currently use to personalize treatments to make our drug selection and dosing procedures a bit more precise. So if we're able to somewhat predict an increased likelihood of toxicity or lower likelihood of response, we can change our selection and dosing strategies accordingly. And so I'll talk about some specific examples as it relates to genetic variation and how this is meaningful for medications that we use. And in doing so, I'll refer to pharmacokinetics and pharmacodynamics, and these are two different terms that pharmacy and pharmacology people use quite a bit. Pharmacokinetics is essentially what the body does to a drug after it's administered. So it involves absorption, distribution, metabolism, and elimination of a particular substance. You hear me talk about cytochrome P450 or CYP450, CYP450 enzymes. These are enzymes that exist in all of us that are predominantly expressed in the liver that are responsible for the metabolism and biotransformation of medications as well as exogenous substances. And there is very well described genetic variation in the genes that encode these enzymes that in turn results in variation in the metabolic capacity or activity of these particular enzymes, some of which are particularly important for medications that we use or prescribe on a daily basis. And now the other end of the spectrum is pharmacodynamics, and this is essentially what a drug does to the body to elicit a response or an outcome. So this is the interaction of a medication with target receptors, transporters, neurotransmitter disposition, et cetera. So they are equally meaningful. There's genetic variation in both ends of this, in both of these categories that we know is important. But the way that we interpret them, I think, is considered a little bit differently. Currently, at least as of last month when I last checked, there are over 160 different medications, FDA-approved medications that have some mention of human genomic biomarkers in the product labeling. And this can be, some of the language related to this can be very detailed, some of it can be a bit vague. Of this 160, a little over 100 have this information mentioned in areas of the prescriber information that I would consider to be somewhat actionable, meaning that it's included in the warnings related to dosing, drug interactions, precautions, those types of things. And about a third of these are related to medications used in psychiatry and neurology practice. So anywhere from 30 to 36 or 37 medications, depending on how you define those. So this is very common, and sometimes these updates of older drugs occur without a whole lot of notice. Most newly approved medications have particularly the drug metabolism genetic studies done as part of their preclinical evaluations with some mention when they're relevant included in the resulting product labeling. So if you just take a quick survey of some specific examples, and this is just what is mentioned in the drug labeling. So this isn't necessarily an all-encompassing list, but I like to show this for a couple of reasons. Not so much to necessarily memorize the entire list, but you can see a couple of themes here. The first is that antidepressants and antipsychotic medication categories have a number of medications that reference genetic variation in drug metabolizing enzyme genes as potentially important for the disposition of these drugs. You'll see a common theme that cytochrome P450-2D6 is populated quite a bit across medications. And this is a drug metabolizing enzyme that we know is responsible for approximately 1 in 5 of all FDA-approved medications that are currently available. Although I'd argue that this is it's disproportionately more important for a lot of the medications that that comprise the antidepressant and antipsychotic medication classes. So it's quite important. And generally, the references here are in relation to individuals who have poor or absent drug metabolism capacity through this particular enzyme system. There's also variation in CYP2C19 that is relevant for some antidepressants that are listed here, such as citalopram, as well as some that aren't listed here, such as Lexapro or S-citalopram, as well as some tertiary amine tricyclic antidepressants. So anyway, the upshot of this variation in metabolizer capacity from the genetic level is that there are hundreds of different genetic or variations of genes encoding drug metabolizing enzymes. So relevant enzymes here that we see and know a lot of variation about, cytochrome P450-2D6, 2C19, 2C9, and 3A5. And they all exhibit different types of variation. The combination or the collation of the variants within a particular gene create a spectrum of activity or metabolic capacity to biotransform drugs or other substrates. And a lot of work's been put into sort of categorizing what is clinically meaningful. And this has resulted in 5 essential categories of metabolizers that are, the frequencies of which are different depending on which enzyme you're talking about. So on the one end of the spectrum, you have poor metabolizers. And these are individuals who essentially lack functional enzyme activity for a particular enzyme as a result of perhaps a deletion of the gene or some sort of genetic variation that occurs in the protein that disrupts the conformation of the enzyme and renders it inactive. On the other end of the spectrum, you have individuals who are rapid or ultra-rapid metabolizers. And these are those individuals who may actually have duplications of genes encoding drug metabolizing enzymes or regulatory polymorphisms that upregulate the levels of the enzymes. In regardless of how that occurs, there's more circulating drug metabolizing enzymes, particularly in the liver, which increases the metabolism and elimination of particular substrates. So you can say poor metabolizer, fast metabolizer. I've always thought I like to have a little bit more tangible information of what does that mean, and is this something that you can generalize across medications, and or is it different? And Sine spent a bit of time over the last year and published a nice paper recently that took a look at some of these things. And so this is, I think this is freely available if anybody wants to get it. But essentially, we took a look at the differences in some of the pharmacokinetic parameters from available information for as far as half-life and overall exposure to antipsychotic medications as an example for this. And what you can see are a couple of things here. If you look at half-life, and half-life is essentially the time it takes for half of the medication that's present in an individual to be eliminated over time. So it's relevant to the amount of time it takes for a drug to get washed out of the body. It's also relevant for the amount of time it takes for a drug to reach steady state at a given dose. The longer the half-life, the longer it takes to get to steady state, also the longer it takes you to wash out of a specific medication. Okay, so what does this mean for individual drugs? Okay, so there's some drug specificity here. So if you look at meds such as aripiprazole, iloperidone, risperidone, pimozide, and thyroidazine, you can see that those who are poor metabolizers have half-lives that are essentially about on the order of 2 times as long as those who be classified as normal metabolizers. So that's fairly relevant for titration-related things. This is not necessarily the case for clozapine and olanzapine, as well as some other medications that may be partially metabolized through this particular pathway, but also have some more active secondary pathways that are meaningful. So there's some drug specificity when you say poor metabolizer, or even on the other end, fast metabolizer. So another important parameter to look at that we found that was reasonably available from available kinetic studies was area under the concentration curve. And this is a measure of overall exposure to drug at a given dose. Okay, and so this particular figure outlines the percent increase in AUC, or overall exposure, in poor metabolizers relative to normal metabolizers. So you can see over here on the left, as you face the screen, you have drugs such as aripiprazole, newer ones, bexpiprazole, iloperidone. We have somewhere around a 50 to 75% increase in overall exposure in poor metabolizers. That seems like a fairly reasonable increase, and something that might be worth thinking about. Some older drugs as well as some newer ones. So risperidone, perfenazine, thyroidazine, anywhere from a 200 to upwards of a 600% increase in AUC in individuals who are poor metabolizers. So this has some relevance to dose-related outcomes, notably side effects and tolerability, and somewhat begs the question of a couple of questions. One is how and when we should use this information, but also another practical question is how often would we expect to observe these things, right? So I tell you, all right, here's a meaningful genetic subgrouping of individuals with a large effect size. How often might one expect to see this in your patient population? So this is an example of how genetic variation can differ across populations for specific genes. So this figure here outlines metabolizer categories on the x-axis here. With these colored bars are different populations, and you can see there's some differences in fast, ultra-rapid metabolizers versus poor metabolizers. With most individuals sort of falling into this what we call normal or genetically unaltered metabolizer range. And so that's one way to look at it. The other is that if you look at the percentages here, you have anywhere from 75 to 95% of people sort of falling into what would, from this context, be described as normal. So the other way to look at that is that's anywhere from 5 to 25% of individuals who have some sort of genetically mediated altered activity that falls outside of that normal range. And if you think about how many people it would take for you to see or prescribe a medication to see a non-normal metabolizer, it wouldn't take very long for you to actually see this. And so if you line this up with other drug metabolizing enzymes, it's actually, while individually the variations are quite rare, in aggregate you end up seeing a fair number of these folks over time. So as I mentioned, this leads to questions and arguably some ongoing debates as to should we be doing this? Should this be part of routine care? How and when? In whom? And I'd argue that we still have a bit of a knowledge gap there. And if you talk to, I was at a meeting one time where somebody from CMS was there, and we were talking about what would it take to get more routine of pharmacogenetic tests in the clinic. And they still view this as needing, landmark style clinical trials that you see a lot of for drug approval processes, meaning you randomize people to get one thing versus another in a double-blind, placebo-controlled type of environment and see what puts an individual in a better place long-term. The problem is that type of trial design, when you're dealing with small genetic subgroupings of individuals, ends up being a bit prohibitive. So what we have is a lot of pharmacokinetic evidence that I described before, as well as some retrospective analyses of clinical trials. So to do those landmark trials with this type of these type of sample sizes would actually be 2 or 3 times more as many people as it would take to actually get a drug to market. So there's sort of this ongoing knowledge gap that we're trying to figure out how to figure out, well, should we test or should we not test? But arguably a question of growing importance is what to do with the genetic information once it's available. And so if you look at what's included in product labeling or what we now have in consensus guidelines that I'll mention in a bit, it doesn't necessarily, they stop short of saying you should or should not get a test in certain scenarios. What they do say is if you know certain information, what you can do with it. So if somebody's a poor metabolizer, they're going to have twice the overall exposure. It seems reasonable to have half the dose, right? So if you know this, then you take action. And this is becoming increasingly important as the cost of genetic evaluations go down and people are obtaining genetic information for a variety of other things unrelated to what you may be seeing them for in your practice, and will increasingly put us in a position to figure out what to do with information even though we didn't make the decision to get it, right? So that's becoming increasingly important. And I think arguably we have a growing desire from providers as well as patients to gain more insight into why individuals are responding the way they are and to optimize treatments. So there are both good and bad things that have resulted from this. And that is that we now have clinically available pharmacogenetic tests, often focused as psychiatry, quote-unquote, panels that you can write a prescription for, write an order for, and have information returned with some interpretation. So the nice part of this is that almost all the panels that I've evaluated, they do have the important genes CYP2D6 as well as CYP2C19. The challenging part is that they also include a number of other pharmacokinetic genes for which the relationship of variation and the kinetic properties of specific drugs isn't nearly as well defined as some of these primary pathways. And then they are also increasingly including pharmacodynamic genes, so variants in alpha-2 receptors, dopamine-related genes, serotonin-related genes, for which there's research available suggesting that they may be functionally meaningful. However, what to do and how to use this information in clinical practice is, in my opinion, a bit more challenging. So, for example, if you have a variation in the dopamine receptor gene that seem to be more likely associated with less robust response to antipsychotics in a trial, how does that help us? right? So if you know somebody is less likely to respond, do we increase the dose? Do we give them clozapine? Do we use ECT? The answer of what to do with that information is a bit unclear. So it may be meaningful. There's some nuances in the interpretation that I think that require a little bit of caution, or at least knowledge of some of the background information. So again, as I mentioned, there's some ongoing clinical questions related to this, some of the scientific questions of what the mechanisms are. I think understanding the variation in relation to kinetics seems to be at least more approachable and actionable as I see things right now. And then, of course, there are practical issues about, well, if I want to get this test, where do I get it done? Can we do it here? Should I send it out? How does it get paid for? And some of those things are moving targets that we can talk a little bit after I get done. One of the things that's really helpful, I think, for us now is that there are groups that are doing evidence grading to evaluate what is the robustness of the evidence for specific drug-gene pairs. That's largely focusing on some of these pharmacokinetic genes. So the NIH has sponsored some efforts by the Clinical Pharmacogenetics Implementation Consortium, or CPIC. And this group is a multidisciplinary group of clinicians and scientists that essentially evaluates how to use existing genetic information in the context of clinical care. And so I had the good fortune of being a part of some recent evaluations of SSRIs and tricyclic antidepressants. So all these guideline publications are all publicly available if anybody's interested. And then carbamazepine has a published guideline related to some hypersensitivity reactions that are related to some immunological markers that are more prevalent in some populations. And antipsychotic evaluation of antipsychotics, atomoxetine, as well as some others, are forthcoming. I think antipsychotics are going to be started from the CPIC evaluation process over the next year. And regardless of what the consensus tables or guidelines come up with, and there are differences of opinion when you get a bunch of people on a call and try to figure out what to make of this information. The nice part is that it does serve as a way to collate the vast amount of literature that's available here so that you can make your own decisions and how these things are relevant for your own practice if you want to. So I thought it'd be reasonable to have a little bit of an interlude to talk about a specific case to make this a little bit more tangible. And this was somebody who was referred to a Duluth outpatient Duluth Mental Health Center clinic that has a psychopharm medication therapy management evaluation process affiliated with it. That we've done a little bit of consulting with. And so this was a 6-year-old individual who, male with a chart history of schizophrenia, depression versus schizoaffective disorder, as well as some medical diagnoses. And so this person had a long history of inadequate symptom response and intolerance to antipsychotics and antidepressant medications. And if we looked at the list, the antidepressant list was notable for paroxetine, fluoxetine, venlafaxine, as well as some others, with a lot of comments about irritability and GI upset that seemed to go along with, be attributed to the antidepressants that were used. And then risperidone and aripiprazole were antipsychotics that seemed to be associated with Parkinsonism in the case of risperidone, as well as akathisia for both. After a medication history interview, it was found that there were, this guy was using 25 different nutritional supplements, reportedly at a fairly regular basis, to self-treat an assortment of different things. So anxiety, sleep, things for his stomach, and diarrhea. So there was a clear need to try to figure out what was going on and optimize therapy for this individual. The referral came along with a request to consider genotyping, and we obtained a psychiatry-focused panel. The one that was selected was predominantly based on some knowledge that this one might be covered by this person's insurance. more than, do we think this one is best versus others. So that was the practicality there. The results for this person were notable in that he was a CYP2D6 poor metabolizer, which was most relevant for his current medication regimen. They did report results for some other drug metabolizing enzymes as well as some pharmacodynamic markers. But in the context of CYP2D6 poor metabolism, if we took a closer look at his medication list, which seems like a reasonable spectrum of antidepressants and antipsychotics to try, all of them happen to be significant CYP2D6. So somewhat by chance, but somewhat by the importance of 2D6 being important for a lot of medications we use, this individual had a history of intolerability, probably in part driven by a genetic predisposition to not metabolize these medications very well. So this was used to recommend changes to ziprasidone and escitalopram as antipsychotic and antidepressant alternatives that are non-2D6 substrates, which seem to be better able to be titrated and at least seem to be working well, at least last time we looked into this. We've learned that sometimes having more information is not always better. So it's on the one hand, you think, wow, it'd be great to know all this pharmacodynamic information. But when a report comes back that says DRD2 and somebody is a non-responder, not less likely to respond, explaining what that means and what to do with it, actually causes a bit more trouble than it's worth sometimes. And so it takes a bit of counseling to put some of those things in perspective. So more is not always better, is I guess my take-home point there. Yeah. Yeah, so the question was, is it relevant to obtain concentrations for some of these things? And the answer is yeah. And some of these, some medications such as risperidone, I think you can get serum concentrations for aripiprazole. They are available. Then, if they came back high, then you could perhaps infer a metabolism abnormality. The caveat is that there are also aspects of drug interactions that can make that can change one's metabolizer phenotype from normal or reduced to poor. And so knowing the genetics is an important piece of that, but certainly the concentration is helpful. Not always, depending on the drug, not always used in clinical practice though. I think and that leads to an important point, that genes are not deterministic and need to be considered as just one larger piece of the therapeutic puzzle. So understanding what somebody's history has been, what other medications they are on, how they may be interacting with a larger drug regimen, as well as somebody's genetic predisposition is extremely important. So I know there's some hope that having these tests is a magic bullet to figure out all the answers for why somebody's responding or not responding in the way that they are, but really it's just one additional smaller piece of information that might be helpful. So anyway, as I mentioned, there's still some room to figure out how to further optimize our treatment strategies, regardless of whether we have clinically available tests now. And I use that as a transition into more of a research-focused portion of the talk, and some examples of how I think this can be helpful there. And so, I've been using antipsychotics as an example because of a lot of our research has focused on this. And we know that they can do very positive things for patients when they're tolerated and able to be, tolerated long term. Unfortunately, we know that 12-month discontinuation rates are quite high. Response rates, depending on the type of trial design, range anywhere from 40 to 70%, depending on the population. We have a great amount of variability in the types of side effects and response rates that we see from person to person. So there's certainly something else going on besides drug metabolism and primary pharmacodynamic targets that might be reasonable. And pharmacogenomic research study designs, I think, are helpful. And they're not only helpful for parsing apart mechanisms related to drug response, but also non-pharmacologic interventions. And we've started to collaborate with some individuals on this as well. So if you have a group of study participants who undergo some sort of longitudinal evaluation of pre-post assessments for either a drug intervention or a non-drug intervention, generally you get a spectrum of sort of degree of desirable or less desirable improvement. And what we can do is do hypothesis generated or discovery-based genomic approaches to see how or what areas of the genome might be influencing response to your treatments. And so this can be helpful in characterizing or validating clinical biomarkers that might be useful, but also insight into mechanisms that we didn't know about before. And so with the accessibility of genome-wide and sequencing-based technologies, which I'll put a plug in for our genomics center here, which is the best of any of the places that I've been as far as their ability to be doing this in a cost-effective manner, really makes this useful for areas of ongoing research. And so one of the things that I became intrigued with earlier on in my career was the role of variation in glutamate-related genes and how that might be influencing aspects of antipsychotic response. So, all currently approved or available antipsychotics have a primary mechanism of action of dopamine D2 antagonism. But all of our animal models of disease, or most of our animal models of disease, were based on pharmacological manipulation of glutamate receptors. So NMDA receptor antagonists, such as ketamine is an example, would produce behaviors in rodents and non-human primates that seem to be akin to some sort of psychosis related phenotypes. We know that healthy individuals, when prescribed ketamine or PCP, will exhibit cognitive symptoms, negative symptoms, sometimes hallucinations. Individuals with psychosis who are given these medications will have an exacerbation of these symptoms. But then administering D2 antagonistic antipsychotics can reduce or ameliorate some of these symptoms, meaning that antagonizing dopamine seems to have an effect on something that was caused by a disruption from the glutamate system. So there's some early description of variation in one form of glutamate type of receptor, metabotropic glutamate receptor type 3, that highlighted how a particular variation in this gene influenced the degree of expression of an excitatory amino acid transporter in the dorsolateral prefrontal cortex of brains from individuals with postmortem brains of schizophrenia individuals, and that in persons who were undergoing an NBAC working memory task who had this lower functioning genotype, their dorsolateral prefrontal cortex had to work extra hard if they had this sort of lower functioning variant related to this gene. And so we thought, well, maybe this is also relevant to treatment response in some way. And so when I was at the University of Iowa, we had some genetic data from a longitudinal trial, fixed dose pharmacokinetic trial of olanzapine. So this was six weeks of individuals with schizophrenia treated with olanzapine. We went back, did the genotyping, looked at degree of response, and saw that individuals with a variation in a transcription factor binding site that was putatively related to some glutamate-related hypofunction seemed to have the most robust response in negative symptoms from olanzapine administration. So it's sort of some idea that well, maybe olanzapine is able to reduce some glutamate hypofunction through some mechanism or another to elicit a better negative symptom response. And then there were some follow-up studies done by Eli Lilly that seemed to find some consistency with this variation, one that was closely linked to it. So that was very exciting. And about that time, I had the opportunity to move to Chicago and be a part of some large programmatic first episode psychosis work in the Center for Cognitive Medicine there. And these were large collaborative studies of individuals early in the course of illness to investigate aspects of neurophysiology, cognition, and symptoms, both before and after antipsychotic monotherapy. And because there was a significant focus on treatment effects, the inclusion criteria for the research side of the program, so there was a research side and there was also a clinical endeavor that focused therapies on early course individuals with early course illness. But those involved with research were based on prior lifetime exposure to antipsychotic medications. So by definition, to be enrolled, they had to have less than 18 weeks total exposure. We had, which I haven't seen in many studies since, we had 75% of our individuals were completely antipsychotic naive. So we had fairly good outreach to catch people the first time that they were sick and seeking treatment. And if they had been treated, they were 3 to 5 days free of any prior treatment, primarily of the course by course of them self-discontinuing medications before they went into treatment. A treatment protocol which encompassed risperidone monotherapy at fairly standard doses for early course individuals. And what was rewarding for me as a pharmacology person was the collaborative nature of the psychiatry and psychology interactions with this. And so we had some, there were a lot of efforts on that side of the research crew to assess how drugs are having positive as well as adverse effects on aspects of cognition early in the course of illness. And so there's a range of different types of assessments, and the types really don't matter for the purposes of visualizing this, but suffice to say there's a fairly standard neuropsychology battery that was administered, as well as some psychotic eye movement tasks to assess some basic aspects of attention, spatial working memory, response inhibition. And what was found was that this was really helpful in profiling, at least visualizing, some of the things that got better from before to after treatment, as well as some of the things that seemed to be adversely affected by antipsychotic exposure early on. And these were individuals who were followed in parallel with healthy, untreated individuals. So it took into account practice effects when those were relevant. So from the genetic standpoint, I found this was interesting because, okay, if we can figure out a little bit about why some people are doing better and some people are doing worse, that seems to be fairly relevant. And also it was insightful in that some of these cognitive markers didn't necessarily correlate with symptom response. Right? So if we looked at our population as a whole, most of the people had an improvement in their symptoms, predominantly positive symptoms, as measured by the BPRS. We had a spatial working memory task that is one example of something that appeared to get worse over time after risperidone exposure. And this is something that had been observed in some non-human primate studies of this type of eye movement task as well. So anyway, it looked like individuals went from performing 3/4 of a standard deviation worse than controls to nearly 1 point standard deviations below the performance of control before or after treatment. But when we took a look at genetic variation in that glutamate receptor that I mentioned before, we found something very intriguing. And that was that most of the individuals who performed this task that we had genetic information on actually didn't have a whole lot of decline over time from before to after treatment. And this decline that we observed as a mean overall was really driven by a subgroup of individuals with variation in sort of this transcription factor related, site-related gene. So it was a very intriguing example of how outliers who have a very robust response, different response than genetically unaltered individuals, can drive what we see in an overall study population. So anyway, we found that to be extremely exciting in a few different ways. And then, so that was a nice example of how hypothesis-driven work can gain some insight into, drug effects, particularly with antipsychotic medications. But then I mentioned this importance of well, maybe looking beyond where your street light is shining and taking a more discovery-based approach. And we can do that with genome-wide association studies, meaning that we take a look at hundreds of thousands of different genetic variants across the genome and see if there are loci that seem to be more robustly associated with response, or if there are patterns of higher level associations that seem to make sense in some ways. And so each of these different dots here represents one of over 600,000 different polymorphisms that were assessed. And their place on the y-axis here is the degree of p-value degree of association that it had with change in clinical symptoms, improvement in clinical symptoms over time. And because you're looking at hundreds of thousands of different predictor variables, your stringency for false discovery is quite high. So what we found was that there was actually one particular, some markers in one particular gene called GRID2 that seemed to be robustly associated with symptom response. And when we looked at this further, we got excited because this was a glutamate receptor type of gene. It's a human glutamate receptor delta 2 gene, which is involved with AMPA, ionotropic glutamate receptor signaling. It's robustly expressed in the brain. The more A alleles that individuals had at this particular genotype, the less likely or less robust response they had in terms of BPRS change over time. And so this was a novel finding, and this was, to my knowledge, the first genome-wide association study of antipsychotic response in first episode patients, and so we were pretty excited about that. And particularly that we found a highly associated marker that was expressed in the brain, known to interact with other types of glutamate receptors, and in some early preclinical studies of memantine, had actually been knocked out in some rodent studies and found to alter response to that medication, which is used in the context of Alzheimer's disease treatments. So that was exciting. And then we took this one step further and said, okay, well, maybe it's not just one. There seemed to be things of importance that went beyond just this one particular finding. So we then took a look at the top 500 associated polymorphisms in our study sample and then accessed some publicly available information from the CATIE schizophrenia trial of those individuals who had been treated with risperidone and found a couple of additional interesting findings. The first was that in the top 500 genes that were associated with the degree of clinical response to risperidone, there was a dramatic overrepresentation of SNPs in glutamate receptor genes relative to what might be expected by chance. And so this was observed in our first episode as well as the CATIE study sample. And then when we took another way to look at this data is to sort of look at pathways. So not so much do things fall in sort of a category of receptors, but how are they related more broadly to biology? We found enrichment for genes implicated in neuron development as well as synaptic signaling were represented in anywhere from 13 to 42 genes that were covered by some of these higher level SNP associations. So it really gave us some insight that, beyond the low-hanging fruit of, drug metabolism and primary pharmacodynamic targets, that there are pathways and other receptor systems that are potentially meaningful for understanding how these drugs are really working in the brain. And so, and I think serves as a good platform for moving this type of work forward, and in particular excited about that in the context of first episode efforts that are happening here. But also sort of circling back to where I started, I think we have, we're at a point now where we understand some of the benefits, but also limitations of clinically available pharmacogenetic tests that we can start to thoughtfully consider, some ways they might be useful in the clinic here. I think we're poised to do that. And that carrying on pharmacogenomics research or just genetic studies in general of treatment interventions can be fairly productive in improving our understanding of how interventions work for people. So with that, I will wrap things up and happy to take some questions, but I just want to say thank you again for inviting me to be here with you, and thank you all for braving the cold to come over to spend time with me and everybody else today. So thanks.
Thank you so much. And we do have time for discussion or questions. We've saved the room a little bit longer today to be able to do that. So I'll move the mic around and welcome your questions.
Thank you very much. The current state of when do you choose to test and why? We saw some of the data, but in terms of clinical implementation, how do you make those decisions about which people to test? And it seemed that part of the information that you presented was people who don't respond very well, that sort of increases your ideas about perhaps we should test, but it sounds like it's more complicated than that.
Yeah. So that's a very good question. When to test, and how do we consider who in whom we should be doing this? And so I'll start with sort of an opinion and where things are going, and then circle back to where they are now. So I think knowing that a lot of the things that are more tangible to me seem to be those related to kinetics and dosing and titration. And it seems to me those are pieces of information that would be helpful to have early on, right? So the caveat to that is it's not standard of practice to get that information. It's not standard of practice to for third-party payers to cover that information early on in treatment. So we don't always have it. I think we'll be moving to a point where people will have gene information on file. So I would say, 10 years from now, that would be fairly commonplace. And so we'd be able to perhaps use that information proactively. Where things are right now, and where we've, in a little bit of clinical consulting that I've done with this, is when people have been referred for this, is really after they have multiple trials of things not working out well. Okay, so that the individual I showed you was an easy representation of somebody who gets referred. I mean, the med lists are, they're long. Like literally 15 medications, and figuring out what the nuances are between that and diagnoses, and it gets very, very, very complicated. And so there's an element of, let's figure out why somebody's here, and then can we make this better moving forward? And I think in reality there might be a happy medium in which I think we have a pretty good idea of first and second line treatments for depression, psychosis, and that you try one thing and it's not very tolerable or it doesn't work well. There are things with subtly different mechanisms of action that are reasonable alternative choices. After after striking out a few different times there, maybe obtaining some biologically relevant information may be helpful to prioritize, one of the, 5 additional options that one has. So I know that was sort of a rambling way of answering your question, but it is a bit complicated. I think it's useful early on, but that's not where we're seeing it utilized for the most part.
And that particular method then leaves a patient sometimes for months not responding very well until somebody like you comes in and says, maybe we should do some additional testing to determine this. Why should we have our patients suffer?
Yeah, so the comment was that it takes a long time to figure out sort of this trial and error approach to prescribing medications. If some individuals might have the means to pay out of pocket to get this information, be willing to do that. Others who aren't so fortunate, don't have that at their disposal right now, which is somewhat unfortunate. And so, anyway, the complicated nature of referrals and who's actually who are actually the users for this right now actually creates a lot of this noise that is contributing to the knowledge gap. So you have people with multiple diagnoses, adherence questions, treatments. One piece of genetic information isn't going to be the magic bullet for all of that. And that's very different than something that's a bit more focused and targeted.
My question is about the pharmacogenetics testing for the cytochrome P450 system. Mm-hmm. So can you help me understand what it means to be like how do they define low metabolizer or ultra high metabolizer, excuse me, versus normal. And I guess the other question I have is, is the testing, it's a gene test, so are they looking for specific variants, and are those variants correlated with the enzymatic activity? And then, that's my general question. Thanks.
The answer is yes. So there are known polymorphisms in each of these genes, and I'll use CYP2D6 as an example since that was the one that I was talking about. So we know there are single nucleotide polymorphisms, so point mutations that exist. Some of them exist in places of the gene that are in introns, so they don't really affect expression. Some exist in the promoter region, which may affect expression. Some may exist in exons that alter amino acid sequence and therefore peptide and protein conformation, and thus how an enzyme interacts with a substrate. And then 2D6 is in an area of the genome that is notable for highly repetitive sequences and genes nearby that are very much look like it. And so it predisposes that area to misalignment during meiosis, and so you can actually get whole gene excision or duplication, meaning some people won't even have a functioning or existing version of the CYP2D6 gene. Others may have anywhere from 2 to 13 copies. So the tests that are done generally assess anywhere from 15 to 100 different polymorphisms and use what's called activity scoring to sort of collate what does the additive contribution of all those variants relate to with regard to metabolic capacity. So then that's how one gets defined as a poor metabolizer, ultra-rapid metabolizer, or somewhere in between. And that pattern of variation is different, and type of variation is different in whether you're talking about CYP2D6 versus 2C19 versus some others. Did that kind of answer? So the combination of variation that results in these activity scores and metabolizer variants is as follows. An individual who has two non-functional versions of a gene is classified as a poor metabolizer. Somebody who has one non-functional gene plus a reduced function gene is called intermediate. Then there's sort of the normal range. Somebody who has slightly increased expression would be rapid, and somebody who has more than two full functioning copies of CYP2D6, as an example, is an ultra-rapid metabolizer.
Sorry, I had a...
Where are we going?
I'm right here. Sorry. I was like, is someone trying to talk over me? Thank you, Jeff, so much. And I was really excited to hear about the research you presented at the end with the GRID2, and it turned out to be like in the glutamate receptor and starting to get more into the pharmacodynamic genes instead of so now we're finding out more about the physiology of the disease as opposed to side effects. So I guess I was just wondering if what you found with that research, it's sort of, I think it was in the context of risperidone treatment, but so is having that gene or the two A's or the two G's, if let's say we started incorporating tests for that into our practice, is it going to tell us more generally if they're going to be a responder to an antipsychotic, or is it going to be able to differentiate between the various choices?
I think my answer is that'd be nice, but I think we had the luxury of a fairly well defined early episode population with minimal antipsychotic exposure that allows us to see some of these genotype phenotype related outcomes. The downside of that is that having a readily available equivalent replication study sample to test this in a very similar additional group of individuals, there aren't that many of those populations of that size that exist. So we've started, there's some collaborators at CAMH in Canada who are going to look at this in some of their existing genotype data to see if those associations were observable in their population that had been treated with a variety of different antipsychotic drugs. So I think the answer is having, for it to be clinically relevant, there needs to be more, I think that needs to be validated. So I wouldn't, rush to have this in clinical practice without further evaluation of one, the variant that we found and some of the mechanistic consequences of that, as well as some validation of, well, if we look at this in, a few different populations, we see some consistency.
Question here. In response to the earlier comment about what patients waiting months and then being non-responders, and then eventually you get the pharmacogenomic testing, we have to balance that against the fact that if you were to test everybody, for example, first episode psychosis, 3/4 of patients are going to respond to the first antipsychotic that they're given.
Yep.
And if you've tested everybody, then they're going to respond anyway. How many patients of that group will you affect in a negative way because you treat them on the basis of a genetic test rather than just clinical evidence-based practice? And until we have studies in which patients are managed with and without pharmacogenomics to see what they're cost-effective, which are cost-effective, I think it's premature to be, dropping $1,000 to $2,000 for a genetic battery on unselected patients. And I see this being used in the community in a kind of indiscriminatory manner, with the notion that it is going to give all the answers and clinicians are going to be able to pick the right drug out of the gate. And I think that's premature at this point.
Yeah, I mean, I agree with you in a couple of different ways. I think, the idea of, well, should we be deploying this early on is something, and whether that puts people in better longer-term positions than not, is certainly something that I think we're actually poised to be, contributing to research in that area, and is worth thinking about. I mean, most individuals, even if they respond early on, they end up going to have different types of medications over time. And so whether having that is helpful for subsequent medication trials is also something that's worth thinking about. As far as indiscriminate use is concerned, we've come across clinics where they just routinely order this on everybody and then do whatever the stoplight colored decision report that the company makes tells them to do. And I really think that there's a thoughtful middle ground to this, and that, when our little psychopharm consultation group with this Duluth clinic has been asked about this, one of the questions that I ask is, well, what would you do without the information? Okay, give me three things that are on your radar to change as opposed to what somebody is doing right now. And that will help me tell you, well, will getting the genetic test result back even be remotely helpful for prioritizing one of those drug selection options? And then there's often a lot of times where nothing that we would get back would be relevant for any of the options moving forward, and it would just be, as you mentioned, a waste of money. So I do think that there's there might be some strategies to have more thoughtful deployment of this type of information. Good. I appreciate the comments.
A comment and a question. I'm a lab geek from Hennepin County Medical Center, so we're struggling with this in psychiatry right now, whether or not we're being courted by at least two private companies that want to do all this testing. And I think the last question hit the nail on the head. Is there an option, what you're going to do actionable for the patient when you get the results back? Because as you said, there isn't any information in the literature, if I understand what you said, that says if you find this color scheme, you should do this.
I think so. So the examples I gave with drug metabolism variants, I think are fairly reasonably described with respect to dose-related things for antipsychotics and antidepressants. Okay, so slow metabolism, fast metabolism, adjusting titration or target dosing to me seems somewhat reasonable, and certainly using that in conjunction with therapeutic drug monitoring might be more reasonable in those who are sort of genetically non-normal metabolizers as well, because there's a little bit of variability there. What we found is that I'm fairly certain I know probably two or three of the companies that you're talking about is that their go, no-go, caution types of color schemes often take into consideration the combination of, well, what do we find with the drug metabolism gene versus what about with the serotonin receptor or transporter type of thing. And I personally feel that interpreting those sort of individually is a bit makes a bit more sense than some of the assumptions that are made in aggregating them. Even though on the surface they seem to be intuitive, but I think in the course of making some of those reports user-friendly, you also make assumptions that may not be ready for prime time quite yet.
Right, but I think one thing you did say is that there isn't a paper out there that would show that the outcome will meet just because it's a slow metabolizer or a rapid metabolizer. There'll be a patient change in its outcome. You hope there will be, correct?
There are.
At least we have. I didn't make it up, but at least we haven't found any really clear-cut, besides case reports.
Right. For psychiatry, we don't have the really large seminal studies that, say, cardiology has. So using cardiology as a comparison, there are drugs such as antiplatelet drugs such as clopidogrel. Warfarin gets a little bit more murky, where there have been studies that have deployed this information and shown that there are some difference in cardiac outcomes for those. And so some of the outcomes that we are able to tangibly evaluate are not quite as discrete, right? So how much Parkinsonism does somebody have? How much do they respond, right? It's different than does somebody have a heart attack and get, so we just don't have those rehospitalization types of studies. So that's sort of made it a bit harder to translate what we know about the kinetics to what does this do for a number of hospitalizations over time, if that sort of makes sense. And certainly, as Dr. Olson mentioned, that with experience, I think oftentimes individuals will titrate as part of clinical practice to the subtleties of an individual's response. So you may eventually get to the same place regardless of whether you use genetic information or not. And that question is, I think, an interesting one that might be worth examining.
Let's wrap up on that note. Thank you all for attending.